Good morning, afternoon, everyone. Today we'll discuss advanced heart failure, specifically when to consider referring a patient for specialized care or a cardiac transplant. We'll cover clinical indications, transplant criteria, and contraindications to guide appropriate decision-making. Let's start with when to refer patients with advanced heart failure. Key signs include frequent hospitalizations, 2 or more admissions or ED visits for heart failure in the past year, renal deterioration, a rise in markers like BUN and creatinine, cardiac cachexia, unexplained weight loss, medication intolerance, either ACE inhibitors or beta blockers, often due to hypertension or worsening renal function, persistent low systolic blood pressure, typically under 90 mg, escalation in diuretic requirements, such as high-dose furosemide or the need for supplemental metolazone, symptoms like persistent dyspnea with basic activities or inability to walk a block due to fatigue. Lastly, frequent ICD shocks or a progressive decline in serum sodium levels. These signs often indicate the need for advanced interventions. Patients meet the criteria for transplant under these acceptable conditions. Some maximal VO2 below 10 milliliters per kilograms per min with anaerobic metabolism, severe refractory ischemia that limits daily activities and cannot be revascularized, persistent ventricular arrhythmias unresponsive to conventional therapies. These factors highlight a critical decline in cardiac function, making transplantation a viable option. For patients under strong consideration, criteria include a maximal VO2 of less than 14 milliliters per kilograms per min, combined with significant limitations in daily life, recurrent unstable angina unamenable to revascularization, issues like unstable fluid balance or renal function, despite proper adherence to medical guidelines. Mychia class 3/4 symptoms with a poor 1-year survival prognosis, 75%. Let's now address absolute contraindications for transplant. Major irreversible systemic diseases or age over 75, recent cancers except for localized cases, active smoking or substance abuse within 6 months, severe infections, HIV, or significant psychiatric illnesses that interfere with care, advanced hepatic or renal dysfunction unless dual organ transplants are possible. These factors significantly limit the ability to ensure a successful outcome.
Contraindications, relative.
Finally, for relative contraindications, we need careful evaluation. Severe pulmonary hypertension or dysfunction with metrics like FVC or FEV1 below 40%. Conditions such as acute thromboembolism, morbid obesity, or diabetes with end organ damage. Current peptic ulcers, diverticulitis, or cachexia. Lastly, the absence of psychosocial support or commitment to the post-transplant regimen. These are not outright disqualifications but require careful consideration of risks versus benefits.
In summary,
early recognition of advanced heart failure symptoms and timely referral can significantly improve patient outcomes. Strict adherence to transplant criteria helps allocate resources effectively while ensuring patients with the best prognosis receive care.